Hey everyone, let's get started. If our panelists for session 6 can come up, Tana Burke, Jake Harper, and Carol Yarborough. Before we begin, I'd like to thank King & Spalding for their sponsored lunch, and I'd like to thank Fernando Porter for finding the person to turn the heat on. Because we talked to everybody and they said no, but he has the magical touch. So, all right, go ahead, Jacob.
But now I'm like the child.
I'm not going to sit down though. Is this on? Yeah.
Did you need a moderator?
I don't. Are you listed as the moderator?
I'm not, you are.
I guess I'll moderate it then.
Yeah, we don't need a moderator.
He needs to keep himself in moderation.
I just want people to look at.
He was going to be the eye key.
Yeah, I want people to look at me, so that's I'm going to stand up.
If you guys could just stand up and you talk, like,
Okay.
All right. Good afternoon, everyone. Welcome back to day one of the CTeL Digital Health Summit. Hope lunch was great. Thanks again to King & Spalding for sponsoring that. It was very delightful. We're going to be talking now, moving on to a new subject, but really I think if you guys are up for it, I think we really want to continue a lot of the dialogue that we recently had in some of the earlier sessions surrounding things like artificial intelligence, remote physiologic, remote patient monitoring, however you want to define the P word there. And so we're going to be talking a little bit today about what are the existing reimbursement models? What are some of the challenges to reimbursement that are faced today in actually implementing these various models? So maybe what we could do first is we'll have some opening statements, if you like that. I'm a lawyer, so opening statements are fun. And then maybe we just go real quick just to have 5 minutes to sort of talk amongst yourselves. We have this tabletop question about forecasting reimbursement landscape for hospital at home care. We can be a little bit broader than that. Don't need to be specific to hospital at home. That's one of the areas we're going to be focusing on this morning. But let me just give a little bit of background in terms of how I see things as they sit today and in the near future. So a lot of the work that I do relates to telehealth reimbursement, telehealth licensure issues, and that naturally progresses to things like remote patient physiological therapeutic monitoring, other virtual care, virtual check-ins, things like that. And to some degree, things like artificial intelligence and how that's going to be reimbursed. A lot of that is focused in specifically the Medicare program, which has a very I think people have described it as Byzantine type of reimbursement model. And unfortunately, is that funny? Is that Byzantine funny? Thank you. I don't take credit for it. It was a judge who used that in a case about the Medicare statute.
You had to look it up.
And I had to read it, yeah. So anyway, but the model that exists right now is very much physician-centric. Right, and by that I mean taking the facility issues that we'll talk about in a second aside. For most types of services that are practitioner-based, right, they are focused on the provision of a service by a clinician, a physician, a nurse practitioner, a PA, what have you. And that makes it very challenging and very limiting for any other kind of ancillary services, any kind of technology-based services to actually receive their own concept of reimbursement. Right, and so it has to be something that the physician does. Oh, this technology is going to help me to do what I'm going to do, but at the root of it is me as a physician performing a service for a patient, and ultimately that's very limiting. So the Medicare program, CMS, they reimburse doctors on this concept of 3 different criteria to develop their payment models. The first is on the actual physician service themselves, right? The complexity and the labor that goes into their own particular personally performed service. The second criteria, and this is really the big one here, is on what's called the practice expense. And so the practice expense is all the other things that that doctor incurs in providing the particular services. So we talked about the lights earlier and the nursing staff and the rent, et cetera. It also includes all of the technologies that are used to facilitate that service. So it might be something like your RPM device, or if you want to license an AI software, that's part of that practice expense. And CMS, to their credit, have recognized that their practice expense methodology is tremendously antiquated, right? It was developed 50 years ago, 60 years ago, and doesn't really have the capacity in its existing state to take into account the use of vendor-based kinds of products. So indirect costs and things like that, or costs that a practice assumes just generally, are very difficult for that model to capture and then actually reimburse a doctor for. And that creates tremendous challenges in the RPM space to ultimately get someone paid. And so the last is on malpractice costs, which is also, I'm sure, a concern for people, but usually that's a pretty small little bucket there. So I just wanted to provide a little bit of what I'm seeing right now in terms of sort of the technological reimbursement aspects and how they're very limited by the existing types of methodology. So Carol, I don't know if you want to jump to, if you had some basic thoughts on maybe some reimbursement issues that you're facing in sort of a more facility context.
Absolutely.
Mike here too.
All right. So the payment methodologies are often misconstrued as people focusing purely upon the physician effort and what the physician gets paid. And this is bled over into telehealth reimbursement because mostly it's focused upon physician effort. Unbeknownst to really a lot of us, I was thinking, okay, so the originating site was another facility back in the day. You get paid $37, $38, whatever, to host a patient. The physician would still get their work RVUs or their payment from Medicare for that professional service. When the PHE hit, all of a sudden, when you had to turn all your patients over to virtual, we all thought, oh, wait a minute, there was that G0463 code that we're not getting paid for anymore for in-person visits. And that's $185 per patient in San Francisco. So we got to bill it with a CN modifier, but that paid $40. So when we're talking about payment parity, and that's kind of why I brought it up earlier with our roundtable discussion, is it's really hard to operate on that kind of margin without having full payment parity. And then also, I did want to kind of move things a little bit more into some facts, if that's okay with you. I know that was a good segue, but I'm gonna, yeah. I'm just gonna move.
I feel like my character has been assaulted.
Yeah. So, I mean, those are facts, but so I just thought it was interesting. So when we're all talking about payment, so the AMA has 11,100 codes in its CPT code book. And not all of them are payable, but there's 11,100. And so we get to use 268 of those codes for the next year. That's 2% of the code book. So in 2025, we're going to go down to 112 codes. Again, only 112 codes that are the non-provisional codes on the current telehealth, Medicare telehealth list, or 1% of the CPT code book. That seems really, I don't know, unequal, 1%. And so it just seems weird that the 268 CPT codes, 2% provided pretty much all of the care people received during the PHE. So I don't know, it just seems a little unequal to balance the entire health of a population on 268 codes when there's 11,000 more out there, if they're not procedure-based, that we should be able to delve into and give via telehealth. So the permanent codes are what we traditionally consider telehealth, behavioral health, evaluation, and management. The provisional are the RT, PT, SLP, pediatric critical care, and stuff like that. The question for us is, going forward in terms of a business model, can we base an entire reimbursement model on a facility-based facility-based provider fee on 112 codes. And so in terms of reimbursement models or where we're going towards in terms of value-based care, evidently between 2025 and 2030, when value-based care is supposed to hit the road fully, there are other things that are like pseudo telehealth that are already in the works that really don't pay enough either, like complex chronic care management, principal care management. These all have elements of non-face-to-face virtual care where you're taking care of your patient population with elements of telehealth in them. And so, for people in this audience, and when you're thinking about facility, I'm going to make a confession. Okay, so I didn't realize that chronic care management codes actually had an APC assigned to them. So if you're a physician in a facility-based clinic, you can generally supervise the staff that is being paid by the facility, and they can bill their staff-based time codes on the UBO4, and if there's enough time spent by the physician, they can also bill for their supervisory activities on the CMS 1500. So just kind of mind blown in terms of thinking a little bit more about how we can integrate, maybe an initiating visit for CCM via telehealth and carry that through with the staff virtually. Things like that. And really, when you're thinking about getting paid for things that you're already doing, the conversion rate factor, based on what you were saying about the Byzantine method of this equation, is that they've taken another dollar away from physicians. So now we're down to $32.74 per work RVU. And so that's down $1.15 or 3.4%. And that's all in recognition of the additional CPT codes that were added this year, 356 to that 11, on top of that 11,100. They have to maintain the budget neutrality, and in doing so, they make a cut in the RVU factor to make sure that all the payments are going to equate to that additional $20 million that they give towards Medicare per year. So in their estimations. So these are remote activities. But in terms of moving towards value-based care, this will really help enhance clinicians moving forward, in addition to the work we're doing towards telehealth. But primarily, it seems like when they're introducing these and including RPM and RTM, they are setting us up towards moving towards value-based care where we get paid for patient outcomes as opposed to patients in dire need of healthcare. So that's my 5 minutes.
I love it.
Thank you. Thank you. I've got the Jake approval.
Hello, team. My name is Tana Burke, and I am also the use case. I am from Bon Secours Mercy, and what I did in prep for my discussion today is I reached out to some of my friends in other health systems, and so just to give you a few thoughts around that. I think the biggest thing when I think of RPM, and as well as getting ready for hospital and home, make sure your hospital is good at care management. Because quite honestly, what I think is RPM is just care management on steroids. So really think about that. Choose your vendors wisely, how you document your workflow. The other thing that I think really blew my mind as I prepped for this, 2 health systems that I reached out with that I really knew they did a lot of RPM. Shockingly, they do not bill. And so I don't understand how that can be sustainable. And so I would challenge everybody in this room. First thing you need to do is make a decision on what you're going to bill for and how you're going to bill for it. And when it seems, in my mind, I try to keep it as simple as possible. Put it down on paper, get your compliance folks, your finance folks in a room, and keep it as simple as possible, because you don't want to make it so complex to be able to execute on it. And when you're doing this, like in my opinion, and I'll talk about my health system, everything, we all share the same EHR, so you're either going to do it, you're going to bill through your EHR or you're going to bill through a vendor. And so it's just that simple. And so making sure that, we personally, we did select an HRS as our vendor. And the biggest reason why we did that is we really liked how they did their time stamping, so that when we did our billing, we felt that we'd be pretty comfortable in how we were going to audit. And so sorry, I grabbed my wrong cheaters this morning, and so I had to rewrite all my notes back there. So I'm like thinking, oh Lord, so be kind to me.
I got an AI code for you.
Yeah, I need it. Be really thoughtful about your model, because one of the things that, somebody mentioned it before, our providers get paid from the RBUs, and we don't want to pick a model that's going to really throw the financial piece of this upside down. You want to keep some of that consistency. We need to keep our providers whole. And so we don't want to make this unsustainable. And so the other thing I would offer is, when you're looking at this, you can probably go about this two different ways. You can look and say, hey, I have 1,000 providers. I'm going to ask each provider how to do this. And they do their own billing. And I'll be honest with you, I think that's going to be complicated. I think the providers will struggle for it because it's hard to interpret some of those. So one of the things that I think a few folks that I talked to, they did it really well, is put your RPM model right smack in the middle of your care management, your case management, and then that way, put that NP there. And so that way you're not asking for an additional burden from all your docs and have all that training and communication. You're making it simpler for them. That way they're doing what they do every day. We're just adding a simple, I'm going to call it an NP, in the middle of that model. They can then do the orders. They can do some of the fulfillment of the RPM and some of the orders related to that. And I just realized I was saying so I apologize for that. Knowing, and I just did it again. Now I'm going to be obsessed with it. So sorry about that. Another big thing that I think I really would encourage, that's going to be super important. My health system, we have 48 hospitals and freestanding urgent cares in several states. Standardize the workflow. Make sure that, that if you're able to share resources, make sure that you have that MP really busy. That way you guys can share resources, because as you even get better at it, that way you can be starting to think bigger. Because in my mind, that's how you start to get into the hospital with home. Because that way, then you're getting that whole continuum of care, right? We're getting our patients comfortable with the technology while they're actually at the hospitals as we get them ready with the RPM. And then it feels more comfortable as we do the hospital in the home. Is part of that standard thing, workflow, which, just so you all know, I'm obsessed with that, and I'm obsessed with measurement, because if you don't have good metrics and if you don't have a real-time dashboard, you're forever looking in the rearview mirror. And I want to look forward so that we're able to proactively change and get doing the right thing sooner. And so I think what good care management means to me in a RPM model is having a great care manager, having a good care coordinator, and then having an MP. And I kept it simple like that. You can mix and match these. But the care manager, they're going to be the ones using the RPM to actually prioritize their work. Because it's always going to be helping them. I'm going to call it red, yellow, green. You're going to know the tasks to focus on. If you have the care coordinator, they're the ones actually looking at more of a dashboard that is identifying some of these patients, and then working with the NP to get the orders made to make good selection into your RPM program. I think one of the so when I say this, nobody be fragile or sensitive to me on this one. One of the things that I think providers, especially our physicians, they want to control, they want that consensus. They want to be able to control everything, but they just don't have the time. So you need to implement a workflow and a reimbursement strategy that is going to be easy for them to support. You can't put a lot of burden on this. So that's what, in my mind, making that RPM, that, care management on steroids, I think makes everything a little bit easier. And the other big thing, my last thing is, pick your technology wisely. It's going to be the foundation for everything you do within your RPM program. And it's going to be your differentiator between when you go hospital to home, because you're going to have all of those things completely tied together to be able to get some good reimbursement and keep your audits to a minimum. And pick your metrics wisely, too.
Amen. So, sorry, before we get to questions, I think it'd be good now, we heard a little bit about the hospital at home program. I'll talk about it in a second, a little bit more, but it'd be great if y'all could just spend maybe 2 minutes at your tables just talking about what your hospital at home program, if you're at a hospital or if you are interacting with a hospital in any capacity, what your hospital at home program looks like, or what you think some of the important operational considerations for a hospital at home program might look like right now. There's currently a waiver at CMS to allow for acute care at home, but this is something that's definitely much more on the minds of different folks. If you want to spend, let's say 2 minutes talking amongst yourselves, and then we'll sort of we'll see if anyone has any good suggestions. All right, folks, I think we're gonna call on a couple people now. It sounds like you had fantastic discussions about something that was not hospital at home related, because otherwise there would not be so much laughter in the room here. Table back there, I'm looking at you. Look, they haven't even stopped talking. So does anyone want to volunteer? I don't think we're going to go around everyone here, but anyone want to volunteer in terms of what they were talking about in terms of a hospital at home program, what's worked, what hasn't worked, what have been some interesting experiences? We've got a table over here. Do we have any mics? I have all the mics here. There you go. No, there's none.
Hi, so I'm Molly Case. I'm from Parkland Health in Dallas, Texas, and hospital at home is one of the things that we've implemented at our hospital. It's been up and going for about 1.5 years, I believe now, and we're averaging about 50 patients a month. And so we have quite a large swath that it moved through. One of the biggest takeaways I think that we had, and it kind of combines the combination of RPM plus hospital at home, is our vendor was able to do both. So the vendor that we had brought in to do RPM could also assist us with our hospital at home efforts. And so that was a huge plus in getting that turned around a little more quickly, because we didn't have to integrate yet another vendor into our system, educate, the patients on one device, and then have to, as you transition them out, maybe onto an RPM program, learn a new device. So that was one of the big takeaways that we've had for our healthcare system.
That's such an excellent point that people get caught up on. So really take note on that one. Choose a vendor that can do both, because it makes it really hard if you use 2 different vendors.
Right here.
All right, so loved your and being that use case. And the piece that we were talking about here was a role that I created within our organization as a digital navigator or a digital coordinator. And I think that you stabilize your facility properly with the technology, but the user experience is so important, and that human connection. And you brought up a great point. I don't want to steal it, but we're getting the biometrics, okay? We're able to receive the biometrics. But the channels of communication that comes back and forth, that can't be put on your physician, because they'll lose their minds, okay? And that's where the coordinator came in and draw back. So using some AI and using some other information, the digital coordinator and the digital navigator, and making sure you focus on your UX.
I love that comment, because we use coordinators also, and it's a differentiator. And because it's a good patient experience, it's a good provider experience, as well as it's a easy bedside nurse experience for sort of that transition. I love that.
5-star value base.
I love it.
5-star. Anyone else? I think we can wrap that part. Yeah. Unless you're going to force someone else to talk that doesn't want to. That's okay. Well, anyway, as you heard, I think, and Todd and I were having this good discussion during the break here. I think hospital at home models, as they are starting to develop, obviously it's a fairly nascent existence here, where it's really another aspect of the pandemic, as well as just the technological explosion that we've seen over the last decade that's enabled us to have the service even be remotely available, right? And, like 50 patients a month is a tremendous, that's fantastic. That's a really a huge number from what I've heard. And so I think there's a lot of different ways to do this right now. Certainly, as you said, having a strong workflow, care coordination team, something like that. It's not a physician. Yes, it needs to be overseen by a physician and physicians, but really the service as I've seen it play out, and most times is furnished by RNs, is furnished by care navigator type folks, is furnished by EMTs and paramedics on ambulances. Because guess what? They're outside all day just driving around, and whoa, we have an emergency. Go to this house, make sure this patient isn't in a crisis, make sure they don't have to come back to the hospital and actually go to an inpatient stay, allowing them to actually be serviced at their home, which is much more comfortable. And they get ultimately a very similar kind of service with, unsurprisingly, better outcomes than they would have otherwise had going to the hospital.
And if you keep the time separate, you can also use all those care coordination activities in a different time bank, bill your staff chronic care management time, and also bill RPM as long as it's separately documented and doesn't overlap if an auditor looks at it.
But again, if it's a hospital at home patient and they're sort of a formal inpatient in that sense, you couldn't bill it separately though. Because I think that's actually still,
I'm talking
under the waiver,
about,
it's still a DRG.
I'm talking about hospital to home, but
I'm talking about hospital at home.
I know.
Let's see. Oh no, you're right though. It says hospital to home. I apologize.
Syntax.
Keep going.
Oh, I'm done.
Oh, okay.
I just wanted to point out that as long as, you can't bill RPM and RTM to the same patient, because I think they thought that would overlap too much, which doesn't make sense to me personally, but you can also bill any of those CCM codes with RPM or RTM. So that's a nice combo. Anything not captured in goading the patient towards doing their RPM blood pressure management, you could, pick up the phone, talk to their pharmacist. That gets recorded for CCM. So capture in all those nickels and dimes where we can. Yes.
I do think too, just to sort of wrap up here, you raised a great point, and that's this. There's 3 different payment models that exist as we focus on the Medicare program in particular, right? So you have inpatient admissions that are focused on DRG payments, and that's really something that's driven by the patient's condition, right? What do they have? What ultimately do they need? And that's how that payment is derived. You have APCs in hospital outpatient settings, which are a completely different type of methodology. And then you have physician-based services, which is a third methodology. As we get into this blending of care, right, where care might be done by a physician, but might be done in a hospital, or might be done outside of a hospital, but for a patient who should be in a hospital, that creates a lot of challenges as well, because the fact that you have these 3 separate models, which are fairly incompatible, all sort of butting heads, just like we talked about. Is it an RPM? Is it hospital at home? We don't even know. That's going to be something that's going to have to be addressed over the course of the next year or so. I'm sure CMS is going to look at that as they consider full implementation of the hospital at home waiver, but that's going to be a focal point as you guys are thinking about this, and as the government is thinking about how to finance this. It's ultimately going to have to be perhaps I hope not a 4th, but at least some kind of hybrid model in terms of how that reimbursement works.
I was going to mention, too, that maybe we need to introduce another payment schedule, because AI really doesn't, yes, because AI really doesn't fall under DME. It doesn't fall under physician effort, because AI is now being paid through the Medicare physician fee schedule, 92227, which is the diabetic retinopathy imaging system that Joe was talking about. That is a fully AI diagnosis producing activity. And they base that fully on cross-walking it to another physician type code where they're doing the same type of activity. That doesn't really take in the PE expense you were mentioning earlier, which was It's going to cost money to upgrade your software. It's going to cost money to upgrade your machinery. Can AI really be equated to physician effort? So I think there needs to be another fee schedule.
I know we're out of time, but I have a question for everybody in this room. And you can email Krista and April your question. I want to know, what is the biggest thing that you need clarification on from an RPM hospital at home perspective? What? It can be one big email. It's endless, Outlook. Oh, and we have a survey. There's a survey coming your way, but still let Krista know all the specific questions. Well, because this is how we affect change and innovate in our future, right?